The next one is pneumonia. Pneumonia can again be divided into different etiologic causes, and sometimes it's hard to tell the difference between one and the other. We'll try to differentiate this for you. Viral pneumonias, look for the age. Okay? Children get viruses all the time, particularly less than 5 years of age. Usually the peak for viral pneumonia is 2 to 3 years of age. RSV is a common cause of bronchiolitis, can also cause viral pneumonias. And other causes include the parainfluenza virus, the influenza virus. Again, viral season is fall and winter. So look at the time of year, look at the age of the child. Non-viral pneumonias are more common after 5 years of age. These include strep pneumonia. Even though we have a vaccine against strep pneumonia for meningitis, we can also still, and it helps prevent other diseases caused by strep pneumonia, we can still see pneumonias caused by strep, also by mycoplasma and chlamydia. In other children, we're going to look for strep pyogenes and Staph aureus. Again, to help you differentiate when you're reading the test question, viral pneumonias usually are preceded by upper respiratory infections. And children don't look terribly, terribly ill. They have a low-grade fever. They can have some tachypnea. You can hear some crackles and wheezing. Bacterial pneumonia, particularly the pneumococcal pneumonia, is of acute onset, and they look sicker, more toxic. They'll have higher fevers. You can see yourself making a table right now in your head of which is viral and which is bacterial. Okay? So they look sicker with the bacterial pneumonias. These patients have more localized sounds, like they'll have decreased breath sounds and crackles, more localized over one area, as opposed to viral pneumonias where they're more disseminated. You can have, because of the infiltrate and bacterial pneumonias, you can sometimes have dullness to percussion. Chlamydia, in particular, doesn't cause much fever or wheezing as compared to RSV bronchiolitis. Again, for chlamydia, look at the age. It's 1 to 3 months of age, so it's a much younger child. Also look for a history of conjunctivitis at birth. Probably the most common cause of infectious conjunctivitis in the newborn is going to be chlamydia. Then that can go ahead and progress and cause pneumonias. They have a staccato cough. Try to do that one for you. It's more of a type coughing that they'll have. The x-ray is not terribly impressive, just some mild interstitial markings. And look for eosinophilia on your peripheral smear of the blood. Chlamydia pneumoniae, different from chlamydia trachomatis, okay, is very difficult to differentiate from mycoplasma pneumonia. Usually it's an insidious onset. It's one of the atypical pneumonias. Mycoplasma pneumonia is becoming more and more common, and it causes a bronchopneumonia. And again, it starts off just as a mild cough or cold, and then progresses with hoarseness. And then over the next couple of weeks, it gets worse and then starts to get better. You can really hear a lot of rowels with mycoplasma pneumonia. The best way to diagnose mycoplasma pneumonia is to get mycoplasma IgM titers. That sounds like a test question. A chest x-ray will help you in differentiating viral versus bacterial pneumonias. Again, with viral pneumonias, just some patchy infiltrates, maybe some hyperinflation. With pneumococcal pneumonia, look for an obvious infiltrate. Mycoplasma looks worse than the patient actually sounds or how the patient presents clinically. And with chlamydia, look for lobar pneumonias, but doesn't look too bad. If on the exam they mention the word pneumatoceles, or if they show an x-ray with pneumatoceles, right away think of Staph aureus. It's notorious for causing pneumatoceles. Effusions can be caused by a variety of organisms, so that might not be as helpful. Here we have a child with a left lower lobe pneumonia. There's the heart border, but coming out of the heart border, there it is. There's your pneumonia. Okay? This is more likely going to be some kind of bacterial cause. This is a child with bilateral interstitial infiltrates coming out this way, coming down this way, coming down this way, all the way out. This may be a viral type pneumonia. Here's a child with varicella pneumonia. It's just all over the place. It looks very fluffy. Varicella pneumonia is more common in patients with immune compromise and in adolescents and adults. So you won't see that as much in a younger child. For trying to isolate the organism or find out which one it is, you can do viral studies. A common one is a nasopharyngeal wash, and you can do that, or you can get find antigens in the wash, or you can culture the virus itself. In children, sputum cultures are very difficult to obtain in children. They can cough, and more what you're going to get is spit. They don't cough up sputum like adults do. If the patient is intubated, you can do a suction through the endotracheal tube. A transtracheal suctioning is the best way to get an organism in bacterial pneumonias in children, but they're not very cooperative. So we just go by the information that we already know. These are the common germs at certain ages. And as I mentioned earlier, the best way for mycoplasma pneumonia diagnosis is to get IgM titers. The treatment depends on the organism. So if you're suspecting bacterial pneumonia, the empiric treatment is you're going to say, well, this is the age group, this is the antibiotic that I'm going to use, and also depends on how sick the child is. They're not going to get so much into treatment with antibiotics in step 2 as they will in step 3.